Good morning, everyone. Welcome to our third day of our Connecting the Dots webinar series in celebration of World Sickle Cell Day. This morning we have with us Professor Monika Asnani from Jamaica, the Sickle Cell Unit, and we have Chalissa here from the SISVD team and Kiran, as well as myself, Renee. So here we go. Without further ado, I will allow Chalissa to introduce Professor Asnani.
Good morning, everyone. Professor Monika Asnani. She is a professor of family medicine and epidemiology at the Caribbean Institute of Health Research Sickle Cell Unit, University of the West Indies in Jamaica. She has over 18 years experience for providing clinical care for persons with sickle cell disease. Her focus of research is psychosocial outcomes and determinants in sickle cell disease and sickle cell nephropathy. Sorry. Her work has advanced understanding of predictors of renal function decline in SCD and has sought to validate methods to determine presence of early sickle cell nephropathy. She has validated and tested various tools to examine quality of life in children, adolescents, and adults with sickle cell in Jamaica. She is currently leading a project to assess the prevalence of neuropathic pain in sickle cell disease and is the local PI for the gene therapy in sickle cell disease project. She is a graduate of the University of the West Indies and was awarded the MBBS degree in 1992. Her thesis for DM Family Medicine in 2006 examined the quality of life of patients with sickle cell disease. She completed in 2014 a PhD in epidemiology with a focus on the epidemiology of sickle cell nephropathy. Thank you so much, Professor, for joining us at this World Sickle Cell Day webinar. And we look forward to whatever you have to impart onto us.
Thank you so much. Thank you, Jalissa. Thank you, Renee. I am so honored when I saw the email come from Renee inviting me 2 months ago. I got the email. I was really thrilled and honored to be invited. Let me just say that. And I continue to be thrilled and honored to be with you guys today. And thank you, Kiran, for working through with me and my tech difficulties. So thank you, all of you, and the great work you're doing with sickle cell awareness. You know, Trinidad and Tobago, that's really fabulous work. And I'm really gonna enjoy today and tomorrow being with you as well. So without further waiting, let's get right into what the team wanted me to work with, which is us looking at, I'm gonna share my screen. Looking at reproductive health issues in sickle cell disease. I think it's a great topic to look at for both men and women living with sickle cell disease. And I'm happy for, I have some slides and they're really just reminders for me to what to speak on, I am happy to take questions, comments, and just jump in. Renee, anybody on the panel who is able to speak. What I wanted to see was I had invited at least Carrie Ann. Let me see if Carrie Ann is there. Not yet. Carrie Ann Sanderson. Is she there, Kiran? Not yet.
No, not yet.
She's one of our sickle cell warriors. So please let me know when she joins so I can welcome her as well to the team. She's supposed to be joining us up to this morning, we confirmed. So let's dig right into it. Thankfully, in the last few years, in the last 2 decades, and so medical advances in management of sickle cell disease, growing our understanding of what causes sickle cell disease to behave as it does, from being how terrible it is, why does it behave that way? And we have learned a lot in the last couple of decades about it. And thankfully, that is giving persons who are living with sickle cell disease longer lives, but healthier lives and improved quality of life of their lives. We know there are many challenges that patients with sickle cell disease will face from the time they're babies growing up, right? But yet the medical advances have really, really made quite a bit of difference. So what happens? I remember 40 years ago when I was a little girl and came to campus, because I'm a campus kid as well. I grew up on university campus. I knew my father had colleagues who had sickle cell disease. And so I used to hear a little bit about sickle cell disease. And I know 40 years ago, it was a battle to survive. Okay. And then I forgot all about sickle cell disease till I went into medical school and I saw a few patients. And then 19, 20 years ago, I was invited to come and work at this world-class unit. And there also I saw the battle that exists for, survival, for getting over one crisis after another and so on. But there have been many, many advances since the last 30 years. And so, men and women especially, and I'll tell you why women especially, they don't have to worry so much about, the next painful crisis. So people are enjoying good lives and want to do everything as they must, because sickle cell disease is just a part of what you are. It's not what you are. I'm sure you know that more than me saying it. And so reproduction, wanting to have a baby, looking after sexual health and so on, become a focus as they must, right? So as persons live longer, they're enjoying improved quality of life, reproductive issues are coming more into focus. This is not only for disease like sickle cell disease, even other life-threatening diseases, say cardiac disease and, HIV, any other critical illnesses. Now that people are enjoying healthier lives, they want to have babies, they want to have their regular family lives. And that's exactly how it should be. So issues about reproductive health are very critical to persons living with sickle cell disease. And there are many other considerations, because as medical advances have taken place, there are other effects they may have on persons' reproductive health. So one of the medical advances, is hydroxyurea. Okay, does that impact me on my ability to have a baby, on my ability to have a normal family life? There's bone marrow transplantation, that is a curative therapy. That's a cure for persons living with sickle cell disease. What does that mean for me? Does it, can I have normal babies? You know what I mean? Jalissa said that, we are involved in a gene therapy trial, which is a trial, we are still testing it, whether it will work for persons with sickle cell disease. One of the questions for all of us is, will that still let me have a baby if I was to enter this gene therapy trial? Okay, so we need to talk about reproductive issues. I'll start with a slide on how do persons with sickle cell disease grow, and how is their growth and puberty. So you will know that sickle cell children tend to be a bit smaller for the most part compared to their classmates. Okay. So we know, and this is globally as well as studies that are existing in Jamaica, because of the presence of the sickle cell unit in Jamaica over the last 45, 50 years, there's a lot of research that has come out of Jamaica, and so I will keep speaking to Jamaica at many times, and sorry about that, but there's global stuff and there's Caribbean stuff, and Jamaica does have a large amount of data on stuff. So we know children with sickle cell disease will grow taller at a slower pace in their childhood, okay? And there are various reasons for that. And puberty also for boys and girls will be a bit slower. Okay, but you will know that by the time persons with sickle cell disease reach adulthood, they're not short. They might be slimmer, right? But they're not short anymore because they have caught up. Their growth catches up. Okay, and our puberty in any human being is dependent on our growth. Okay, we require a certain amount of body mass index and height and weight before our puberty erupts. Okay, so because our height is slower, because that overall growth is slower, our puberty can also be delayed, and this can be a problem for children. Imagine you are 13-year-old, you're in a classroom, and all the other girls are looking nice and curvy and getting little breasts and so on, and you might still be flat, and boys may be short, and that's a no-no. And other guys are just shooting out, maybe getting a facial hair, and we are not getting it. So my talk to my youngsters like that is, trust me, I don't have any women who don't get breasts. I don't have any boys who don't grow tall and get their facial hair and get their private parts looking just like anybody else who doesn't have sickle cell disease. It just happens a little bit slower, but it's going to reach there. So it might occur at age 15 in girls versus age 11, okay? So puberty is a little bit delayed, but I think if children with sickle cell are told all of this and encouraged that, what is going to happen? Don't worry about it, okay? Just enjoy your childhood a little bit longer, and then you're gonna shoot up, all right? Because it does happen. Puberty is delayed, but it will come on in a couple of years. There's hardly anyone who will not undergo puberty normally, just like in a non-sickle population also. There can be kids who have endocrine issues, some kind of hormonal issues, and in that case, they will be referred to a specialist to see, are their testosterone lower or estrogen levels low for some other reason, okay? So sickle cell can delay growth, sickle cell can delay puberty, but it will happen. In fact, not just height, in fact, our sickle cell patients are probably a little bit taller, okay, the young men, because their bones don't fuse as quickly. So they tend to get taller. And whether we like it or not, and it's a little bit disturbing, and a little bit that we all have to be cautious about, is that as people are living better, we are seeing people getting overweight and even obese. In the last couple of studies, research studies that I have done in the last 2 or 3 years, we are seeing almost 20% of our groups that we have examined to be overweight or obese. So you see, soon enough, we might be entering this other extreme where, from being very, skinny people, I know a lot of our young people would say, boy, they call me puny and they call me, all of these kind of things. We might be reaching the other side of the balance scale, and we don't necessarily want to reach there, because we don't need anybody to be overweight and obese.
Professor,
Yes.
I've read where, as related to the delayed puberty, that it may be related to a nutritional deficiency in a lot of minerals that we have. So do you think that improved nutrition can help?
Improving nutrition will help every aspect of disease. So you are very right, Kiran. Sickle cell body is an overactive body, okay? Because so your body, from the time you are born, for the body to manage their sickling that is occurring, it is working overtime always. And so nutrition is being used up much more rapidly in a sickle cell person than a person who doesn't have sickle cell. Because remember, in a sickle cell person, which is a red blood cell disorder, your red blood cells are dying way quicker. I do not have sickle cell disease. My red blood cell lives about 3 to 4 months, about 120 days, okay? Whereas for a person with sickle cell disease, their red blood cell may live for 10 to 20 days, right? So that factory that's producing blood cells, which is your bone marrow, is working overtime to keep up with these quickly dying cells, right? It has to keep up to be producing cells. So we definitely need more nutrition, okay?
Yeah.
So you have an excellent point there that adequate nutrition helps and can probably make quite a bit of difference. The second thing is that every time we go into a sickling crisis, a pain crisis or acute chest event, which are all sickling crisis, we burn even more energy. And you could probably tell me better that when you're having a crisis, you're eating even less. So you see, that's a double whammy. So nutrition is key, Kieran. I can't tell you whether an excellent diet will cut out this delay in puberty, okay? But it will definitely slow it down, meaning the effects will be less. So excellent point. Excellent point.
I know for me, my puberty was delayed as well. I started seeing that menstrual cycle probably only at the age of 14 or 15.
There you go.
Whereas everyone else I knew, had already started.
How did that affect you?
I think probably emotionally, mentally a bit, but so a little disappointed, like what's wrong with me, that kind of thing. But I don't think it had a lasting impact. After everything started, like if everything was normal.
Yeah, yeah, yeah.
My son was very, very small. So he was in secondary school and looking like he in primary school.
Right.
So he'll be with his friends and he's like everybody's little brother, really little brother. When they take out pictures, everybody towering over him, even in primary school. When they took out the class picture, he looked like he was in standard 1 and everybody else in standard 5.
Yeah, yes.
And now he is the tallest in the house.
There you go. There you go. Yeah, it's not even a laughing matter because I am sure it is very disturbing. For us when we were growing up, if we think back 40, 45 years to when we were at that age, it's, you want to be just this much taller, this much taller, this much taller. And, getting breast, are you going to get it or not? Oh my God. Yeah, boys especially, because 12-year-olds, and we have 12-year-olds who look like 6-year-olds or 7-year-olds. It must be disturbing.
That is exactly what was happening.
But I think if we can keep them a bit hardened, yes, it is there, but trust me, you're going to shoot up and you probably will be the tallest in the class. It's just a little bit slower. And these are the issues that are critical, because if it affects your self-esteem growing up at that age, it can last a lifetime. Obviously Renee is not disturbed even at that time with it. And social support, I think, is the key shot. And so for caregivers to learn as much as possible, for moms and dads and families, and then the wider communities. I think somehow even I feel that, my family must love me anyway. But when you get that support and love from your external communities, your school, your teachers, your friends, and when you come to work, your colleagues, it just means different. That support is amazing. So
yes, I'm glad you said that, because it didn't affect me as much as I think it would because I had that support family-wise, and then I was already a member of the society.
Oh, wow.
So yeah, I think that helped.
How big is your society and how old is it?
I think it was launched in the 80s, 1987.
Wow.
Yes.
Wow.
So my parents, when my sister and I was diagnosed, they joined the society through the advice of Dr. Waveney Charles. So we grew up in the organization.
Wow, wow, amazing. So I think the peer support, I always feel a little bit of an outsider, because no matter what we say, no matter what we think we understand about sickle cell disease, I do not have it, So when you speak to your peers, they can understand it, versus somebody like me trying to hold your hand and say things in a different way. It means a lot, so yeah. I think the psychosocial support is the key shot, and it can really make a difference. Pain and all other kind of things. I think if we knew that psychosocial support and how to improve managing and coping, it can make a huge difference in patients' lives. even physical complications. So 2 slides on what happens with sickle cell males, right? You know priapism, and you know what priapism means. I'm sure your audiences knows, but priapism is a condition which is basically what happens in priapism. You have a painful erection of the penis, okay? So usually young boys growing up into teenagers, and of course adult men, will have erections, okay? They might have erections and waking up or whatever. These are normal events, okay? But when an erection comes with severe pain, then it is called priapism. And usually it is not associated anything at all with sexual thoughts or sexual activity, okay? So I don't know of priapism occurring when a young man is about to, enter into a relationship or having sexual contact with his wife or partner. But it is a non-purposeful, this not related to sex. You get an erection and it comes with a lot of pain. Studies have shown that up to 40 to 50% of boys and men with sickle cell disease can have priapism. So I say boys because I have seen boys as young as 6, 7-year-old. It's not very common in that age, but I have seen young boys on the ward with priapism, okay, sickle cell boys. But typically more common as we enter adolescence. Adolescence begins at age 10. So even studies that are there out of Jamaica and other countries, 10, 12, 14, 16 common. And then the median, the average age when priapism may begin is about age 18. And it can go on. You can get your first attack even in your 30s, okay? Up to 40 years, you can get your first attack, okay? But it's most prevalent in adolescence. So imagine a 10-year-old or a 12-year-old, for whom penis is not something you want to talk about. The issue is that, so whenever I have seen young boys in clinic, I would talk about this purposefully because you want the parents and the child to understand that this can happen. And I tell them this is like having a painful crisis in the penis, which is exactly what it is. It's a painful crisis in your penis. And you have to tell your mom or your dad about it if this is happening, because a lot of times we'll feel ashamed of it because it's something happening with your penis. They just know that, it's something wrong, because we always tell them you have to hide your penis and you have to, cover up yourself. And obviously, so knowledge again is key. So once you tell them that this is a pain crisis, it is something that you must tell your family about as soon as it is occurring so it can be managed. It is important. If it is not managed properly, and if they get what is called a major episode where a priapism attack may go on for longer than 3 to 4 hours, it can lead to erectile dysfunction, which means inability to have proper erections. Imagine young men just entering young adulthood and they're not able to get erections. Now that is a devastating problem, okay? So priapism is something, and you see the data there, up to half of your boys and men can suffer from this. Some may just get one attack and never have it again, and some may have it over and over every night, and so on and so forth. Kiran, you're going to say something.
I think in Caribbean society, I think that idea of the dysfunction could be devastating for any male, right? Because talk with peers and then even interaction with the opposite sex. And you can't get your boy up, That talk, and it's common in the Caribbean. It's common in the Caribbean.
It is in the Caribbean, especially. This symbol of maleness. And nothing wrong with that. Nothing wrong with that. You might think that other communities maybe don't talk about it as much with fun as Caribbean men do, right? Because I think we Caribbean people are a lot more open and engaging. But I am sure it is devastating for any young man, whether he's in Asia or Greece or US or UK, that, oh my God, what's going on? Why am I not getting the morning erections that I used to get, for example? And then worse, to find a girlfriend or thinking of getting married, and you cannot, because if you cannot get an erection, then you cannot have sexual, you cannot enjoy any sexual activity. All right. So that is a problem. Kiran, you have something else to say on this, or?
No, not at the moment.
Yeah. So other things that can happen in sickle cell males. So we know that, sickle cell disease is a blood disorder, and blood flows to every cell, every bit of our body, every organ in our body. Blood has to travel there because blood is what carries oxygen, and every little speck in our body, every cell, every tissue, every organ needs oxygen to survive, to live. So because sickle cell is a blood disorder, it affects every organ in the body. Men can have low testosterone. Testosterone, everybody knows, is a male hormone. It makes the men. Okay. Women also have some amount of testosterone, just as men will also have some amount of low amounts of estrogens, which are the female hormone, but this is what they have. But because where is testosterone produced? It's produced in your testes. Okay, and testis is an organ. Okay, your testicles is an organ in your body, and your sickling can affect your testes, and for many different reasons, the testes may not produce as much testosterone as is needed, and so in up to a quarter of the men, they may have low testosterone levels, and how that impacts their lives can be varied, but definitely there may be lower libido in men. So it may be due to low testosterone that they have lower libido, but also remember sickle cell disease, you're anemic. That's the main problem, right? You're anemic, and if I don't have sickle cell, if my blood count, hemoglobin is usually 13, and for some reason I bleed out and my hemoglobin goes to 9, my energy level is going to drop down into the boots. I probably won't be able to move much. I might be having shortness of breath with it and so on. Of course, persons with sickle cell disease typically have 8 or 9 hemoglobin. Many of them will have hemoglobins of 5 or 6 that they're walking around with, but their bodies have adapted to that pretty much, because this is how they have lived their lives with, our body is a very adaptable machine, so their bodies have adapted. Yet they may have lower libido, just lower energy levels, which can manifest as lower libido. These are what I'm bringing up here are issues we all need to be aware of, as persons living with sickle cell, as healthcare providers who are looking after helping people with sickle cell. A lot of studies show that men with sickle cell may have sperm abnormalities. The density of the sperms, how much sperm they have in the ejaculate may be low. This count number of sperms that they have may be low. And the sperms may not move as well. They may not be as motile. And sperms really are rapid fire, like gunshots that they need to just get to those eggs to fertilize. So they may have those kind of problems as well. And there are concerns what hydroxyurea may do to your sperms, and I'll have a slide on that as well, because it is a significant thing. As I said in my first slide, what kind of effects are all these therapies, or might these therapies have on our reproduction? Quick issues, quick couple of slides on females. So starting from puberty and starting from menstruation, I mentioned some of this already, that menstruation may be delayed, and we spoke about it. Renee shared her experience on it as well. And the delay is greater. The more severe the sickle cell disease, we know typically we speak to SS disease being more severe than SC disease, S beta 0 thalassemia being the more severe kind of sickle cell disease. The more severe the sickle cell disease type, the greater the delay in your menstruation and puberty. What is the other problem with menstruation in sickle cell women? Okay, menses may be irregular. Okay, again, because your hormones are what our hormone balances in our bodies is what determines our menstrual cycle on a monthly basis. Okay, and hormones are produced by various endocrine organs, such as the ovaries in our body. And the same way, as I said, testes can be, impacted by sickling in the men. Same way, ovary function can also be impacted in the women and girls with sickle cell disease. So their periods may be irregular, they could be quite heavy, and it could be associated with what we call dysmenorrhea, which is just painful periods. Now, what we have learned in the last few years is, and you probably know it from before me, Renee and others, is that a lot of times period pain can bring on an acute crisis. Okay, up to 30 to 35% of young girls will say that they go into a crisis every time they're having their period, right? Now, this crisis, it doesn't have to come on as your period is starting. Even premenstrually, 5 to 7 days period before that, before the 5 to 7 days before the period begins, while the period is ongoing, and even a couple of days after the period is gone, girls can have painful crises as a result of that. Menstruation is known to be a stressor that can bring on painful events in pain crisis in girls and young women with sickle cell disease. Okay, so we have to be very cautious about that, and we have to manage that, right? If girls know, if mummies know that every time my little one is going to go into a period, she might go into pain, then we need to make sure we have medications and all those things available to manage that. All right, what about contraception? I know when I started working with sickle cell disease people, will say, you know, why aren't you, you know, you're starting sexual activity, why aren't you on any family planning? Oh, doc, you know, I went to my clinic and they wouldn't give me any family planning. There's a lot of discomfort and maybe low confidence in managing persons with sickle cell disease in healthcare facilities. Why? You know, asthma is a very common condition. High blood pressure is a very common condition. Diabetes is common. Sickle cell is not as common. I know I saw very few sickle cell patients while I was a medical student and a young physician, till I came to work at the sickle cell unit. Obviously, all we see here is sickle cell disease. So your confidence, you might be more worried as a healthcare provider, what works and what might hurt people with sickle cell disease. Okay, but contraceptive counseling is very, very important. Okay, what we have found is that women with sickle cell disease, young women with sickle cell disease, need contraceptive counseling, as well as they need to be using contraceptives to prevent pregnancy, because the effects of a pregnancy can be so much more severe in women with sickle cell than women who don't have sickle cell. And that is what I'm going to speak about a little bit later. Pregnancy is the main issue of concern for sickle cell women. And we're going to talk about that. So these are women who really need to be on contraceptives so they don't get into these unplanned pregnancies here and there, and, you know, just kind of, you know, you have a nice little night with your boyfriend and you weren't really planning on getting pregnant, but end up pregnancy. You know, unplanned pregnancy, we don't need that kind of extra burden on a person, a woman's life, especially a woman with sickle cell. So it's important to counsel them about contraception, but reproductive counseling is also important. Now, as you know, and it might be, I look at ourselves as healthcare providers and I say, you know, we are so busy sometimes when we see our patients, young people growing up, just talking about, where's your hemoglobin today? Are you taking your hydroxyurea? Were you in hospital? And how do you prevent leg ulcers? And how do you prevent getting into a pain crisis? That we forget that these are young women who are thinking of wanting to go to school, want to make a career, have a boyfriend, want to get married. Sometimes we ourselves might be forgetting those things and not paying attention. Whereas when I see other teenagers who don't have a chronic illness like sickle cell, then I'm asking them all of these things. Do you drink alcohol? Do you smoke? Or do you have any depression? You know, these are the kind of things we know we must ask our teenagers in every medical visit. But we sometimes forget those things which are so critical in sickle cell people, because we are so busy managing what we think are really life-threatening conditions. You understand what I'm trying to say? To balance that, it's important to balance that. So what studies have shown that healthcare practitioners are not talking to sickle cell teenagers about reproductive choices and counseling them about reproduction. And contraceptive utilization, meaning people using contraceptives, sickle cell people using contraception, is lower than non-sickle cell people. So sickle cell people are using less contraceptives. When I came to the unit, I used to hear the mummies would say, but they can't get pregnant anyway. Okay, we'll talk about that in a minute. The thought is that maybe sickle cell girls are not going to get pregnant anyway because of their sickle cell. And there's no such thing. They will get pregnant. They will get pregnant. I'll show you that. Any kind of contraceptive can be used. Okay, there's a big fear that if you use the pill, which we know can cause clots, it's going to give clots in sickle cell girls. So we're not going to give the pill. Okay, the pill is one of the safest contraceptives, the most widely available contraceptive, and it can be used because we know the risks that come with a pregnancy can be so severe that when you balance the risk of a medication versus the benefit of a medication, the benefits of using OCP to prevent a pregnancy are much more than any risk that you think you might have with the clot. It's like, we have the COVID vaccines and everybody worried about clot, so they're not taking it. Do you have that problem in Trinidad?
Yes, I think so. There has been a lot of
Vaccine
skepticism about the vaccine and everyone afraid to get it and so on. But I think that has improved now. I think everyone is rushing now to get the vaccine.
But I think, we seem to have a higher acceptance ratio than many parts of the country.
Fabulous. Hats off and thank God. Because, you anticipate, but guess what? People have clots all the time, even if they didn't take the vaccine. People don't balance it. And COVID is real. And we have seen 3.6 million people have died with this pandemic. It's scary. 3.5 million people who wouldn't have, most of those wouldn't have died otherwise. Okay. So there's this thought that there may be a risk of clots, but OCPs, for the most part, are safe to use. Progesterone-only medications, such as Depo-Provera. Do you have Depo-Provera in Trinidad? Which is a single injection that's given every 3 months to prevent pregnancy. Do any of you know about it? It's the commonest method used in Jamaica and many parts of the world.
Yeah,
I'm not quite
we
familiar.
have it, but not sure how common it is. But
really?
yes, it is available.
In Trinidad,
privately.
in Jamaica, every GP can give it, every health center gives it widely. Why? Because guess what? It's a single injection given in your bottom, okay? And it lasts for 3 months, which means a girl or a woman doesn't have to think of remembering to pop a pill every day. So this is 4 injections for the year, and it is one of the most effective, 99+% effective against preventing pregnancy. Okay. The other thing with Depo-Provera or progesterone-only contraceptives is that they actually improve painful crisis. Remember, we spoke to painful crisis, especially with menstruation and so on. And that is because of the hormonal changes that are occurring around each menstrual cycle. Okay? Depo-Provera negates that, and it actually, a lot of women who are taking the Depo-Provera will say that they're having pain crisis a lot less. So it's a double, actually it has another benefit. So it reduces painful crisis. It will prevent pregnancy, is one of the most effective methods to prevent pregnancy. And number 3, what the Depo-Provera does, especially after a second injection and a third injection, it stops your periods actually, okay? You don't have a period again. So you see, Jalisa, really happy about that. A lot of us want to see our period every month, but we don't really want to.
I should have known about that in my time.
There you go.
Yeah, so, I'm definitely taking notes.
No, because guess what? Guess what happens? If your period as a sickle cell woman is heavy, you're already anemic. You don't need to drop another gram every month when your period comes. So
but
it
Professor,
has that added.
My period has always been very light.
Okay.
Is that common, or is it more common to have heavy periods?
No, I think normal periods is common. sickle cell women may be more likely to have heavier period than other non-sickle cell women, but most women with sickle cell will just have a normal period.
Okay.
Right. So but just like all other women, there, general women in your communities, in your population, with or without sickle cell, some will have light periods, many will have very heavy periods, but most of us will have normal periods. So the Depo-Provera is actually has quite a few very good effects in sickle cell as well. Okay, and all other devices. The issue is sickle cell warriors. You need to go out there and make your nurses, make your doctors be more comfortable, tell them to read up the literature, but you have heard it, and it is it is out of the NIH guidelines, it's out of UK guidelines. The risk of a pregnancy is way greater, and I'm going to show you that, than any risk associated with any contraceptive. So a doctor would be able to advise you, because there are people who should not take the OCP. Women who smoke a lot should not use OCP. I'm not talking about sickle cell women. If I'm a smoker, I should not be using the pill because the risk of clotting is higher. If I have some other risk, for example, if I've had clots before, clots in my legs or anything, or pulmonary embolism, I should not be using OCP. So a doctor would be able to advise you, just like any other woman who wants to use the OCP should have a visit with a doctor first and then start the OCP. So bottom line, most important to use contraception, and any method you want to use is safe, but it's important to use something when you're getting into sexual activity. Use your family planning methods. There were issues, I mentioned this earlier, people used to think that you can't get pregnant. People thought women with sickle cell were infertile or took time to get pregnant, okay? And maybe 40, 50 years ago, literature or science showed that as well. But guess what? Remember 40, 50 years ago, maybe a lot of women were just dying young, okay? So we didn't see a lot of pregnancy. You get me? You see how we start thinking of a few things. We put 2 and 2 together and end up with 22. But maybe it was that a lot of women just weren't having sex or weren't reaching the ages to get pregnant, okay? But now that women are living longer, then they are going to get pregnant, okay? Jamaica has done quite a bit of work looking at pregnancy in sickle cell. Prof. Sargent has done a lot of work, and I continue to monitor some of the pregnancy stuff here. Our women are going to get pregnant. So when I see young girls or their mothers, I start talking to them from the time they're 12, 13. So, because, young girls are getting into sexual activity, or sickle cell girls are going to be a little bit later because puberty is a little bit later. You're not really thinking sex. So there's delayed menarche, meaning their onset of menstruation is delayed. We said that already, their puberty is a little bit delayed. And delayed coitarche, what this means is the time that they start having sex is a little bit delayed. So they may start having sex at 16 instead of 13, unfortunately. Teenage pregnancies have always been high. I don't know how it is in Trinidad, but in Jamaica, we continue to struggle with teenage pregnancies, because as soon as girls are reaching puberty, they are getting into all of these activities, okay? But sickle cell girls, we know, and our own data, our own studies in Jamaica have shown us the same thing as well, that the age of sexual initiation is a little bit delayed for them as well. So their first pregnancy is about 4 years later, age-wise, than non-sickle girls, okay? We know that. And they may have less sexual contacts, your social behaviors are a little bit affected by sickle cell. You don't go out as much, maybe growing up, especially teen years, is when a lot of pain crises can occur. And so you might be getting into more serious relationships a little bit later than girls without sickle cell, but you are going to get pregnant, full stop. So we say this to every girl with sickle cell: don't imagine that for some reason you might not be able to get pregnant, okay? Just imagine once you start having sex, your risk of getting pregnant is just the same as any other woman, all right? We have to remember that we can't be caught blindsided by a pregnancy. You get what I mean? That is sad. This is important. Has Kerry-Ann joined us? Chrissy. There is, she's labeled herself as Chrissy. Hi,
Oh,
hi
is that her?
everyone. Hi, Chrissy. Is she hearing me? Carrie Ann hasn't written her name, but she's written herself as Chrissy. And if she's there, then she'll say hi. And so there are other things that we need to consider when we, as families, as persons living with sickle cell disease, how do we disclose our sickle cell status to our partners, right? Are we asking our partners to get tested? All right, Renee, you have sickle cell disease. You know, you don't even have the trait, because we're not talking about trait people here at all, because it is significant even for people with trait to know their partner status. It is critical for them to know it, because before they know it, they can end up with that they never had sickle cell disease, they lived quite fine, and boom, they end up with a child with sickle cell disease. You see Jalissa shaking her head. You want to say something about it?
I knew I had the trait, but my husband didn't. His family didn't mention it really. And I didn't know to ask either.
Why
So
not? Do you
it's
mind
only
if I dig into you? Why didn't you know to ask?
because I just knew that I had the trait,
Mhm.
but my parents never really told me how important it was
Right.
to know what it was about. I knew, okay, I had sickle cell trait. That is as much as I knew.
You didn't know its implications.
No.
There you go.
I found out all about sickle cell trait when I had my third son, third child. And at 3 months old, he got a very high fever and his belly was looking a bit distended. And when we took him to the GP, he checked and he told us to go do the tests. That was it.
That's where your learning began. And here you are
Yes.
now, part of
Yes.
the society and a very active member, I can imagine. Yeah, and this is how it goes, you know. So you might know that you have sickle cell trait, but you don't know what it means. It's like, you know, okay, well, I'm half blind, so I need to wear glasses, but it doesn't really mean, your sickle cell trait didn't even mean that because you had no issues with it. You know what I mean?
No.
Exactly. So this is why, you know, this kind of awareness is critical, but especially with persons with sickle cell disease. Imagine each child you have to pass down one abnormal gene to that child anyway. Yeah. You know, at least if you have the trait, you have a 50% chance that you will only pass down, you might pass down the normal gene, the A gene, okay? Yeah. But a sickle cell disease man or woman is only going to pass down an abnormal gene to your child, right? So partner testing, at least in Jamaica, we have heard stories over and over. I'm afraid I don't want to ask my partner. Number one, many of them will say, I don't want to tell my partner. A lot of them are afraid they will lose their partners if they disclose their sickle cell status. This is for sickle cell disease people. I've heard these coming out of our patients here. They don't feel empowered to tell their partners. And even when...
One of the things, Professor, I will say, from my experience when I was a lot younger, is, I mean, I always told people that I had sickle cell, but sometimes you meet a girl or you have a girlfriend and they tell their parents that you have sickle cell. And the parents say, hey, you know, he go dead, yo.
Oh, God.
You know? Wow. He go leave here, you know. And so I think part of the thing is because there wasn't that much awareness, right, and about the condition, and we live a lot longer now. But I think then the thought was that we will all die young, because that I used to get that from a lot of people from primary school group, right? And then the other challenge is then as you grow, sometimes as much as you know, you get into a situation and something happens, right?
Yeah.
So it's like in my case, with my first child, I got pregnant before we tested, right? So my girlfriend got pregnant before we tested, but luckily she didn't have anything, right?
Okay, no trait.
But that's the thing with life sometimes, and I think there needs to be a different approach in terms of how you educate or teach persons who live with sickle cell to approach that situation with their partners, because it's not always an easy thing to approach from the beginning, or to come on, you meet somebody and you ask them to get tested.
Do you have any advice in terms of that?
That was my question. Do you have any thoughts?
Who, me?
Any of you? Any of you?
Well,
Yeah.
what I have 2 sons,
Mhm.
and having found out about sickle cell, I told them, if you see a girl and you think you might like her,
Mhm.
before you even talk too much, ask her if she has sickle cell, if she has a trait. So, and if she said yes, just walk away.
Oh no.
Obviously, all of these situations.
A mother is allowed. A mother is allowed. So she's doing the flip of what your girlfriend's parents were telling her, right, Kieran?
Yes.
Alyssa
Yes,
is saying the
right.
flip side. So, but you okay? So in a lot. Also, what I want to add here is you ask whether she has sickle cell trait or sickle cell disease, especially with the trait. Young women with sickle cell disease, asking your boyfriends if you have the trait, don't just listen to, no man, I don't have it. Ask the next question. Have you ever been tested?
Yes.
Yes, I have been tested.
Well,
Have you seen the result? Have you seen the result? Because many people will do the test, you know, and assume they probably don't have it because nobody tell them about it. Many times, even healthcare providers, we can drop the ball. So I would say, get tested and look at the result and understand what that result means. Because remember, if you have SS disease, even somebody with the AC, the C trait, you can have a child with SC disease, which can be just as severe as SS disease. Okay, so we doctors have learned that when a patient says, when I say to a patient, say with blood pressure, say I have a patient in front of me with high blood pressure, I say, you taking your medications? Yes, doc, yes, doc. And I say, okay, good, let's move to the next question. But then I have to ask them, you know, do you take that medication regularly? Because that is when the real stories start come out.
Yeah.
Then you might hear, well, doc, I take it when I don't feel well.
But
So
it
you know
could
that's
also
not right.
be awkward in terms of if you're in a relationship for a number of years and then you realize that, oh, the person has some sort of trait, whether it be S or C, and you know, what do? Do you just quit the relationship, walk away?
Yeah.
Or do you take the risk? You know, some people may choose to take the risk.
My personal thought, and I'm just one person, has been this. So unlike Jalissa who said walk away, and that is true, maybe you can walk away because you are telling your boys that do this when you start talk, before you really start think anything serious. Get tested, check the partner's test, right? But what I say to patients is, and maybe I'm wrong, but there's another layer that you can't determine who you're going to fall in love with.
Right.
The true love of your life. You meet such a person, you can't, you know, you don't normally decide who you're going to find love with. But you can try to make informed decisions about having a child. Now that is difficult, especially for Caribbean people. Yeah. We Caribbean people are so, our whole lives are so having children and having, you know, a family has to have your own child. We don't think beyond other reproductive choices, such as adoption. And then, of course, if technology becomes so widely available to get in vitro fertilization with, you know, sperms or eggs that do not have the sickle thing, or there are countries that can do prenatal diagnosis. I don't really want to get into that, but you know, if you're pregnant, your fetus can be tested to see if that fetus has sickle cell disease and so on. And there are countries like Cuba who do that, right? With the further option of aborting if the couple decides for that. But, you know, those are other discussions. But you can fall in love with someone and you realize, oops, this person has sickle cell trait. Yeah. And oops, especially because you have sickle cell disease, then my chance of having a baby with sickle cell disease is 50-50, right?
But I think
you-
one of the biggest challenges we have, at least in here in Trinidad and Tobago, is that well, more so in Trinidad and in Tobago, because a lot of people don't know the gene exists in their family, right? And
Exactly, that's what
we don't have
happened with
newborn
that.
screening, right? We have newborn screening in Tobago, so babies
you
being
guys
born
have
in
newborn
Tobago now
screening
could
in
find out.
Tobago. Yeah.
Yes, in Tobago, so families in Tobago have been finding out that they have the gene,
Yeah.
right? But in Trinidad, it's not happening,
I know.
right?
So you
Trinidad
guys
is
need
where
to lobby for that.
Yes, right. So
Because you know who lobbied for it in Jamaica? The Support
Dr.
Foundation.
Okay, yeah.
So you have the power more than any doctors.
Yeah. Well,
So you
I
need
mean,
to lobby.
the society has been trying, but the challenge, one of the challenges we face here is because our health system is so decentralized.
Yeah.
Because even though the ministry might have overarching control to some degree, the hospitals are independently run by individual RHAs, which are according to geographic area.
Same for us in Jamaica.
Yeah, so they have a lot of autonomy, right? So you can't necessarily force them to adopt certain programs.
Yeah.
Right?
But while
Unless
you
it's a
continue,
nationwide policy.
while you continue to lobby with the government and the regional authorities and so on, you also lobby with the population because they can get up and get tested.
Yes.
Right?
Well, that's one of the things we hope to do. As a project, we hope to begin soon, even on a small scale, and I guess even if we start on a small scale, the evidence will tell us a lot.
Because you know, knowledge is power, and what I say is, you know your status. This is our you know, advice, our plea. Know your status.
Still wants to ask a question.
Because what I say is, remember, the sickle test is a one-off test. You don't need to get tested second, third, 10th time. It's not like HIV where you want to have a test every year, you know?
Yes.
This is a one-off, get tested. There's a hand up, Edlin.
Yes, Edlin has deal.
Yeah, good morning, Prof.
Morning.
What I wanted to ask is, in Jamaica, how widespread is your newborn testing? I mean, I wanted to ask that not about how widespread is it?
Since 2015, every baby being born in the public healthcare facilities is supposed to be tested for sickle cell disease. This is, since 2015, is in effect. Now, how successful it is, it's pretty much high up there. We did not enforce this on private facilities yet, but there's no enforcement with any facility, but this is a recommendation. But even if a baby is born, say, in a private hospital, they are well able to avail newborn screening. They can carry in their baby for a free test, you know, at any government facility or so, including sickle cell unit, and get tested. So we have universal newborn screening in Jamaica, but only since 2015. We lobbied for a number of years, because remember, the first work that was done on the benefits of newborn screening in sickle cell disease was done in Jamaica by Prof. Sargent's group when they did that big cohort study in the 70s and early 80s. And after that, it shut down. So island-wide newborn screening is occurring since 2015, Edlin.
My follow-up to that question, Dr. Prof, is what then, because I'm aware that Jamaica has the same kind of decentralized health system with regional health authorities, right? We here have a challenge in trying to get that sold to our policymakers. And do you have any advice on how we could go forward as a society to make it happen? How much lobbying, that kind of thing?
Boy, that's it. You know, lobbying it is, right? And governments have so many different things to manage. But let me tell you, newborn screening is one thing to enable. The second bit that has to be put in is early childhood care. You need to put in facilities to manage babies that are being born with sickle cell disease, because you're going to be picking up a few babies. And but the benefits of newborn screening in babies getting proper care, because you know they must start getting their care, their penicillin prophylaxis and their vaccinations and so on from age 3 to 4 months. In fact, age 2 months, right? Because if babies can access that care, their early life deaths even out with the rest of the general population. They die no more than other babies being born without sickle cell disease, which is a huge benefit. You know, sickle cell disease will kill in infancy. In sub-Saharan Africa, where you have the largest number of births with the disease. So these are the kind of data I would think as a researcher is what is needed, Edlin, to really push at your governments. I don't know how much data is collected in Trinidad regarding sickle cell disease. And because you guys have a large Indian subpopulation as well, there is the presence, probably the presence of beta thalassemia is much greater than other nations. And this is one thing I wanted to say to you before I forget the point, Kiran, in newborn screening for trait testing. And we were talking about testing your partner, because a beta thalassemia trait can be missed. It's a little bit difficult to pick up. So if you have sickle cell disease, as you do, Renee or Kiran, when you need to get your partner tested, you have that test done on a specialized center who really understands to pick up the beta thalassemia. Because whereas a sickle trait is much easier to pick up, beta thal is not so easy to pick up. Sorry about that divergence, Edlin. I don't know what to say except that we can have a full chat on that. And I can have Prof. Madden and Dr. King, who have really been actively engaged in the newborn screening. We have a full sickle cell technical working group that has been put together for the last 5 or 6 years. It's an arm of the Ministry of Health. So even though we have decentralized care, 2 regional health authorities, and we have 4 to cover 4 sections of the island, there still is the Central Ministry of Health. So each region, so the Sickle Cell Technical Working Group has members from the Sickle Cell Unit as the doctors and the researchers, and it is led by Ministry of Health officials, okay? And then we also have representation for the Sickle Cell Support Foundation. They used to be called the Sickle Cell Support Club in the past, Renee. They are now renamed as Sickle Cell Support Foundation of Jamaica. Very active and very vocal, and they really get work going. So I think, and then you have to work out a plan to show them a plan, and Jamaica already has such a plan. So if you wanted to engage that way, you need advocates. So you are advocates. If you get a couple medical advocates who are really keen into, Dr. Charles was one such person, you know, a couple of people like that, and then you find 1 or 2 people in the ministry who may be able to push your voice forward. And then we have a blueprint together, which is what is working in Jamaica. You know, you don't have to reinvent it. You might need to adapt it for your setting, for your health authority systems. But,
I'd always hoped in my life that one of these days, one of the officials at the Ministry of Health, God forbid, end up with some kind of relative, close relative.
I know. But this is a reality, you know, that's how you get advocacy. If you can pick somebody who wants.
You get some buy-in from that level. The other question, I want to, just an aside from, as I say, I have to go out just now. We had a webinar this week reporting on the newborn screening in Tobago. And out of that came the information that 1 in 7 people tested for and there's fairly widespread. They're catching over probably 90% of the births in Tobago, right? 1 in 7 people born with the trait. So that was really very scary for me. Because all along, Dr. Charles would tell us 1 in 10. I remember many years ago in the 80s, I had taken 20 of my friends from my office to test to the lab in Port of Spain General Hospital. And it was 20 of them, and I found 3 traits. So I'm saying
out of 20. That's
but they are reporting in Tobago 1 in 7. Which is critical.
Scary, that's more than 10%. How much is that?
That's
scary. About 13%.
13.5% or something like that.
Wow.
13.5%. So I'm saying if that is the prevalence, then we have a avalanche of sickle cell disease coming down the road.
And would you know, Edlin, if this was, because I missed that talk yesterday, I think it was, or Wednesday, the one on newborn screening. Was it only the S trait or all traits?
No, that was all traits.
All traits? Was it all or S? No, just S. I think it was SM, but we could look back at it.
But I could
Look at
share that.
it.
I could share those slides with you, Professor.
Yeah, because so in Jamaica also, and this has been consistent over the last 40 years, we have 10% of the population with the S trait. Another 5% of the population has some other hemoglobin disorder gene, like the C trait or the thalassemia trait. Okay, so on a whole, 15% of Jamaica has some kind of abnormal gene that can give them a baby with sickle cell disease. You get me? Because remember, S is not the only thing.
Yes.
So Edlin, that's important to look at. But whatever it is, I mean, 13-14% is a huge rate. And you know, I guess all of us in the Caribbean are fighting same battles, but you know, advocacy will win. As I said, it took us years, 15 years or so of just pushing to get newborn screening, island-wide newborn screening. So maybe we can have some kind of a together. You need to find 1 or 2 partners in different areas, and obviously the society is obviously a huge partner because you are all so committed to this. But this is, you know, it's like penny wise, pound foolish. We know all of that, but you know, I know Jamaican government, I can't even fault everything they do because all of us want our little corners to get the attention. Yeah. And we fight for it. And we have gotten it. For example, we got on our National Health Fund, we got sickle cell disease listed as one of the Jamaica's National Health Fund illnesses, which allows patients then to get their medications on a subsidized rates, you know. Yeah. So we have had a couple of good successes, and we continue to push for more things that our patients need.
We have a little quote among ourselves: no trait, no disease.
Oh.
If we have no trait, we have no disease. So we have to find the traits wherever they are.
You have to find the traits. You have to find the traits and get the counseling going.
As we on the topic of reproduction, I have a little question. And relating to, I know there are new, I know you're all doing research into gene therapy, and I know there's also stem cell therapy and CRISPR and whatnot. So
right.
The thing is, our condition is an inherited condition, but if you undergo one of those therapies, right, like whether it's stem cell or genetic therapy, can you still pass the gene on?
Yes. Yes. So the gene therapy, for example, my unit, and I'm the PI on that part, we have sent 2 of our patients up because there are a few gene therapy trials taking place in sickle cell disease. CRISPR is one gene therapy, it's called gene editing. The kind of gene therapy I'm involved in is called gene transfer. So they are really to improve outcomes in the person who is going to get the gene therapy, but their genes that they pass on are not changing.
Right.
Yeah, so that's a caution there. Chrissy, I just want to welcome Chrissy a minute, please. This is Carrie-Ann Sanderson. She's a sickle cell warrior, and she is a lead in really, and you know, she's not even formally engaged with the foundation or anything, but on her own, she's really taken on this mantle of supporting persons living with sickle cell disease, and especially the western end of the island where Chrissy lives. Chrissy, you don't want to turn on your camera a minute, or you? I'm not pushing you to, but you want to? If you can, you please do so we can see you.
Hold on a minute. I'm using my phone.
Oh, okay. Okay. How are you? You've been here listening to some of our chats. Is there anything you want to add on here?
I'm fine. I've not a problem because using the
problem with
data in and out.
Okay, with data,
So
I'm sorry. Oh, there you are.
Data plan.
Oh, I'm sorry, Chrissy. I'm sorry.
What you do, the connection is low, so she could probably take off the camera.
Yeah. Okay. So if you're on data plan, take off your camera. We have seen you, and we'll listen out for you. If you have anything to say, so just jump in. You hear, Chrissy? This is Carrie-Ann, ladies and gentlemen. And I'm so happy you could join us.
Sure.
Take off your camera because then we can hear you better.
Okay.
Yeah.
Okay.
especially on this slide, Carrie Ann, even though Renee has shared, Jalissa has shared, Kiran has been sharing as well. Anything you want to tell us about how, what causes Jamaicans with sickle cell disease not to want to talk to their partners or tell them about their status, that I have sickle cell disease? Have you ever been through that mental thing to say, boy, I don't know if I want to tell him about my sickle cell,
No, I didn't have a problem telling my partner about having sickle cell. I've been a straight up person. I really talk to him and let him know that I have sickle cell. I go in crisis now and again, but I didn't have any problem explaining to him. But what I observe, most Jamaicans ladies, they are afraid to speak to their partners that they have the sickle cell disease. They don't want to talk about it. They just want to stay in their shell. They don't want to come out into the light and explain it to their partners. I don't know why they're afraid of doing it, but I think it is best that ladies and gentlemen should talk about their sickle cell and finding the right partner for that child not to come and have the sickle cell disease, not to suffer like the mother or the father.
So could you get your partner to get tested?
No, I didn't get my partner tested, but he didn't have the sickle cell disease. So my kids, they only have the trait.
Okay. But that's a chance, right? Because if there's no test, there's no way of knowing.
Yes, I know.
Yeah. So Chrissy, I've heard different things from men, and Jalissa said something totally different. So, you get different ideas to bring together to make us understand better how different people may be thinking. I have young men, who I have interviewed about stuff like this, and young men who once said, you know what, I don't want no girl. And, again, the Caribbean maleness comes out here. I don't want girls to treat me like I'm a sicky. Which is, you can understand, right? I don't want nobody to treat me like I'm sicky. Actually, this is something I get from even women and men, okay? That sickle cell warriors don't want to be looked upon as somebody sickly and who can't manage, or, don't do this, sit down, you're going to get sick if you do that. I think a lot of patients are demanding that they don't be treated. They will handle pain if it comes, but let me do what I want to do. I want to play like everyone else. I want to do things that everybody else does, and I will take my chances if I get sick. And so we need to understand all of that as family members and so on, and doctors and nurses. But the men, especially talking to their girlfriends, they don't want to come across sickly,
right?
Or that they don't want a nurse. They want a girlfriend. They don't want a nurse. That is what one male patient told me. Doc, I don't want her to be nursing me or feel like, or leave me because she thinks she's going to have to nurse me. And I don't want nobody to treat me like I'm just like a puny boy.
Right.
Chrissy, that's what I've heard quite a few men say about disclosing their things, So, but it's so important to disclose the status, because that's a very important step before you ask your partner to get tested. And of course, the other flip side is that a lot of young women, as I'm sure is prevalent in the rest of the Caribbean, don't feel that they can ask their partners to get tested. They don't feel empowered. Just like a lot of women, and forget sickle cell, can't say to their men, I need you to wear a condom. Women don't feel empowered to say these things, and we need to understand that, okay? Again, we have found that when you do newborn screening, you have a baby born with the trait, Kiran. Edlin is gone, but, and you say to the mother and the father, all right, your baby has sickle cell trait. But is that baby going to be counseled and reminded when he or she reaches 10 or 12 or 15 years of age or 21 years of age?
Yes.
You know what I mean?
Yes, constantly.
We don't need that disconnect. That is the important thing. Even a parent may forget that my baby was born with sickle cell trait.
As young as my children, I remind my children, and I let them know how it is I got it and how they can pass it on to their kids. You know?
Yeah.
So as long as they are, they know.
It might be more in your, you know,
So,
in your life
you,
because you
yeah,
are dealing with the disease. But
that's
when,
what I was just going to say.
Yeah.
The reason we constantly reminding them is because we constantly dealing with it. But
yeah,
when it's just the trait and nobody else's thing, you know?
right.
But I mean, there have been instances, I mean, when they were younger, when I was in hospital and they weren't able to see me, and they know I was in hospital
Yes,
because
exactly.
of sickle cell. So I think those things are a bit of reminders to them.
Oh yes,
And
absolutely.
a simple thing like if I have to put drops in my eye for my own eye health, I let them do it, right? So I tell them, you know, if daddy don't do it, daddy could go blind. You know?
Yeah.
Yeah. So I agree, but I think this is the most important part. This is one of the most important parts to decrease, you know, the numbers of babies being born with sickle cell disease, etc. This is a very important part, and it is difficult throughout the world. Everywhere has the same issues, but this is somewhere that I think peer groups can really help with and empower each other and support each other and getting that word out, you know, more than us doctors bickering about it. So just a quick slide. I know Kieran had asked me about this as well. Hydroxyurea and reproduction. Bullet one, does it affect male fertility? There is some concern because the way hydroxyurea works, it affects rapidly dividing cells, and sperms are always rapidly dividing as well. Will it affect sperm development? And you know, there are studies that have shown, yes, it may have some effect, and there are studies that don't show much effect, okay? It's difficult to decide because we already said in one of the earlier slides that sickle cell disease itself will cause sperm abnormalities. So if a child is given hydroxyurea, as they should be, because let me tell you, and I'm digressing again, when you have those little children on hydroxyurea, Jalissa, you won't know that child has sickle cell disease because he's growing the same rate as anybody else in his class. He's doing his education level is just as good because, you know, sickle cell children, their cognitive abilities, ability to learn may be affected because if they keep getting this sickling crisis and what we call minor strokes going on in their brain, they might not be as smart, or their grades may not be as good. And plus, if they're getting hospitalized all the time, they're missing so much school. We know those have been real issues, right, Kieran?
Yes, and that's one of the first topics we touched on this week. And Dr. Ebony Lan, she did a really excellent presentation on it, talking about executive function and
exactly
and problems with the frontal lobe of the brain.
Exactly.
You know, she really did an excellent job in explaining.
Those recordings, Kieran, because I really wanted to listen to her as well. But these couple of weeks have been intensely busy for me from morning till night.
Well, it's available on our Facebook page, but we could always
I know your Facebook
send you a link where you can
page.
download it.
I don't do Facebook much, but I do have an account exactly for these kind of things because I know
we will send you a link so that you could download it.
Thank you. Yeah, because it does, right? So, so these kids are growing well, Jalissa, on hydroxyurea in childhood, right? So we don't know if it is sickle cell that might cause these problems with male fertility, or is the hydroxyurea effect is added on. But the general understanding and belief and recommendations are that if you have sickle cell disease that requires hydroxyurea therapy, because the benefits of hydroxyurea are so vast that it must be used. So that is what all guidelines state. So there's no direct studies that are saying, oh my God, if this guy takes hydroxyurea, he's not going to be able to get a child. There are no such things going on. We know it might affect some issues with sperm development, but we know sickle cell will do it too. And because hydroxyurea decreases sickling, maybe it will negate that bit. And so we haven't found any big problems. The idea is hydroxyurea should be used because sickle cell can be so devastating that hydroxyurea can really, the benefits are massive. What about hydroxyurea for women when they want to get pregnant? Even though research is ongoing to see if hydroxyurea, we can continue to use hydroxyurea when, so if a woman can be taking hydroxyurea and now it's time she wants to get pregnant, can she continue it? Recommendations so far are still that hydroxyurea must be stopped when a woman is getting pregnant. So we encourage women to stop it 3 months before getting pregnant, okay, especially with a planned pregnancy, because there is a possibility that it might cause some abnormalities in the baby, because again, a fetus is rapidly multiplying and growing, and hydroxyurea affects that. Even though there are many times, a lot of pregnancies are accidental, and women with sickle cell who have been taking hydroxyurea end up getting pregnant, no abnormalities have been identified up to today in any child being born while the mother was taking hydroxyurea before she realized she got pregnant, okay? But recommendations are still that we should stop hydroxyurea if a woman wants to get pregnant, even though we know that a pregnancy is a high risk event and she's going to get, or she can get a lot of sickling when she gets pregnant, but we advise for now that it should be stopped. Studies are ongoing to see if we can continue to use it in pregnancy, but up to now we recommend that it must be stopped, okay? So that's where we are with hydroxyurea. Pregnancy. So pregnancy, which is the mainstay of this talk, or could be, because let me just say that pregnancy is a high risk event. If a woman has sickle cell disease and she gets pregnant, it is a high risk event. Now, most of our women who get pregnant are going to be okay, all right? Right. They may have some pains in the pregnancy. Many of them will have pains more than what they had before they got pregnant, but their risks are way higher. We have done studies, and we are doing another study in Jamaica looking at maternal deaths due to a pregnancy. In our sickle cell women in Jamaica, we found that risk to be, so every year, women who get pregnant, a few of them will die from whatever complications. And I'm not talking about sickle cell, I'm talking about generally, okay? But sickle cell women getting pregnant, their risk of death is 10, 11 times more than another woman who doesn't have sickle cell disease who gets pregnant. Now, the numbers sound scary, but the numbers are small. As I said, most women who get pregnant are going to be fine and they're going to have a normal baby, all right? But the risks are there. Because women are getting pregnant every day. You see hundreds of them in antenatal clinics. Most of them are going to be fine. Most of them don't even have to go antenatal clinic and they're fine. We want everybody to go to antenatal clinic, so don't take that the wrong way. But that there may be a woman here or there, and I'm not even talking sickle cell here, who can die in pregnancy or pregnancy-related complications. Sickle cell women's risk is higher. We consider it a very high-risk pregnancy. In Jamaica, there's been a lot of work. Always, sickle cell women, when they get pregnant, they go to a high-risk antenatal clinic. In the last 8 to 10 years, there's been more training and etc. of obstetrician, gynecologists, nurses, etc., midwives, etc., in providing maternal care for women with sickle cell disease. So they are now actually high risk clinics where we put women so they get even more intense kind of care and attention during their pregnancy. Okay, they can get more sickling, they can get more painful crisis in their antenatal period as well as immediately after having a baby. Their risk of getting UTIs, urinary tract infections, is much higher than women who don't have sickle cell. They can get acute chest syndromes more commonly in their pregnancy than they did other times. Preeclampsia or hypertension in pregnancy risk is way higher as well. Okay, but not only the mother who has sickle cell disease and who gets pregnant has complications, but it can have implications for the baby as well. Okay, so when a sickle cell woman gets pregnant, the baby she's carrying can also have complications. This baby may be born small for age. birth weight may be smaller. Okay, they may have small babies, low birth weight babies. The babies may have more distress during labor, okay, what we call fetal distress. And the risk of death of baby is about 4 times bigger than a non-sickle mummy. All right, so there are risks to the fetus and there are risks to the mother when there's a sickle pregnancy happening. In fact, the baby is dying, what we call perinatal mortality. This is death of a baby. Was as much as the, studies in many earlier reports from the 50s and the 60s say almost up to half the babies dying. Okay, but they have gotten lower and lower. In our latest report, 7% of the babies were stillbirths in SS mummies. Okay, but it's something to look out for. So that is why management of a pregnancy has to be very tightly controlled. Maternal deaths, the mummies who get pregnant, sickle cell women who get pregnant, early reports in the 40s and so on. That's why we used to tell mummies, or they used to tell mummies, because I was around in those days, up to 1/3 of the women who they got pregnant were dying. So that's why doctors would say, don't get pregnant. We don't do that anymore. We don't do that anymore. And we get this question every day, doc, I want to get pregnant. What do you think about it? You need to have a good discussion with them as to what the risks might be, how to enable you to have a healthy pregnancy, what you need to be doing, and so on. Up to recently, this study was published, the one I'm pointing at, the last bullet here, was published just last month, where Prof. Sargent spoke about this in that paper. 4% of the mummies died in their pregnancy, SS mummies, okay? How do you manage? And I just want to do a couple of quick slides that when a woman comes to you and you all are advocates and leaders out there, peers, a lot of women in the Caribbean, at least in Jamaica, get pregnant without planning it. Okay, but that is why I start talking to these little girls whenever I go into clinic, or when I used to do this a lot more. From the time they're 13, 14, I start talking, and the mothers many times look at me like, what's wrong with you, doctor? You're talking to our daughters like this. They don't usually say it to me, but I can imagine they're thinking it. But I think it's important. And I say to the moms that it's important to start talking and advising as your girls are